Thank you for joining my presentation on infection control in the NICU. My name is Terrence Shenfield and I am the co-owner of A&T Respiratory Lectures, and I am a former education coordinator at a major trauma center in Newark, New Jersey. Throughout my experience, I was in charge of the NICU as well as the Peds ICU, so I have a lot of experience in that unit. I thought I'd bring to you some great topic on preventing infection in the NICU, which is really relative. While I was in the NICU, I was asked by the fellows in the NICU to come up with an infection control presentation that would help their staff, and I came up with this one. So I hope you enjoy it. So what are the problems in the neonates? What kind of problems they have? First of all, they're completely dependent on us for their survival. When these babies are born, and a lot of them are born premature, they have incomplete immunity. In other words, they don't have an antibody system. They don't have an innate immune system that's fully activated. So if they come across any kind of pathogens, they don't have a good way of fighting it. Another concern with them is they have an incomplete antioxidant system. We all heard of free radicals, and free radicals are part of our everyday existence. But as we get older, we develop defenses for antioxidant systems that we can fight off infections and also fight off oxidative stress. These babies don't have that. Another concern is invasive procedures. These babies need to survive. They need mechanical ventilation. They need non-invasive ventilation. They need tube feeding. They need so many different interactions going on with them. So people are touching them, people are sticking them, people are probing them. As a result of all this, the likelihood of introducing a pathogen in their body is really high. So invasive procedures, which are necessary for their survival, actually can cause harm to them. And then we all know that babies that are born premature have incomplete lung development. Incomplete lung development equates to poor oxygenation status and the possibility of mechanical ventilation. Both of those things could introduce infections to the baby. So the baby has a lot of problems, and that's why we're here to take care of them and minimize all those problems. Today's objectives, we're going to be talking about hospital-acquired infections in the NICU. In the NICU, some of these patients are predisposed to certain infections that occur likely in the NICU. Sepsis is being one of them. We're also going to be talking about device-acquired infections. What do I mean by device-acquired infections? Because these babies need artificial hydration, artificial nutrition, mechanical ventilation, oxygen therapy, they're subject to many different interactions through healthcare workers. For example, mechanical ventilation. When you intubate a patient, the likelihood of introducing a pathogen in the airway is pretty high. When you tube feed some baby, you have an opportunity to offer an infection. So device-acquired infections is a significant factor in the NICU. Then we'll talk about ventilator-associated pneumonia. These babies who are premature, their lungs are not fully adequate to breathe on their own, so they're put on mechanical ventilation. As a result of being on mechanical ventilation, the likelihood of getting a VAP infection is pretty high. Also, we'll be talking some basics on hand washing practices, and then I'm also going to talk about spreading or preventing the spread of infections in the NICU. So these are the major topics we'll be covering today in today's presentation. Let's talk about some stats in the neonates. For example, if a baby is born at 25 weeks gestation or greater, their survival rate is greater than 85%. Technology has gotten good, our doctors have gotten good, our nurses have gotten good, our respiratory therapists have gotten good. So these babies are surviving. But there's a flip side to that. The flip side to that is that 29% of these infants who survive will develop some form of hospital-acquired infections. And here's even worse news. If you're born less than 25 weeks gestation, 46% of them will have some form of a serious health-acquired infections. So why is health-acquired infections important? Because there's approximately 2 million cases each year. 50 to 60% of them are caused by resistant organisms. That's a whole discussion in itself. You know, resistant organisms are really tough to kill. There's no antibiotics to kill them, or it's very difficult to kill them. And then there's approximately 9,600 to 20,000 deaths each year from catheter-related infections. So what does that mean? That means as healthcare workers, we introduce catheters to the babies, and 9,600 to 20,000 of them die each year as a result of these type of infections. So these are some stats. I'm sure I could go through a bunch of other stats, but I just wanted to give you a little background. So what are the risk factors for hospital-acquired infections? And some of the major risk factors are low birth weight. If a baby is born premature, most likely they have a very low birth weight. And when you have a low birth weight, a lot of times your lungs are not mature, your immune system is not mature, so you need to be tube fed, TPN, you need to be mechanically ventilated, you need to have catheters inserted to you. So basically with all these things, the likelihood of you getting a hospital-acquired infection is really high. A lot of these babies are born with congenital malformations such as neural tube defects, heart defects, and Down syndrome. Again, this increases the likelihood of getting a hospital-acquired infection. Also, these babies, because they're so premature and they need so much support from us, they get frequent invasive procedures. They get TPN, they get IV sticks, they get heel sticks, they get intubated, they get this, they get that. As a result of all of these invasive procedures, the likelihood of introducing a pathogen, again, is really high. And like I was telling you earlier, these babies who are born premature have an incomplete immunity with antioxidants, as well as incomplete immunity with antibodies. So all of these things increase the risk factors for these babies. As I was mentioning earlier, babies are born with incomplete immunity. What that means that the younger the baby is born, the more premature the baby is born, the more incomplete the immunity system is. For example, the immune system is the basic defenses against any kind of pathogen. And the immune system consists of two parts, the innate immunity and the adaptive immunity. When you think about the innate immunity, think about macrophages and neutrophils. So the babies are born with these cells, and if any kind of pathogen comes in the body, they would mount a defense against that pathogen. But they're not born with enough of them. In regard to breastfeeding, if a mom breastfeeds her baby, they build up the innate immune response by building up the macrophages, which can help the baby. So that's why breastfeeding is really, really important. But if a baby's born premature and ends up in the NICU, that's not going to happen. In regard to the adaptive immunity is your T cells and your B cells, and they are not actually generated until the body comes in contact with a pathogen. So if a baby comes in contact with a pathogen and develops some form of adaptive immunity, that will be hosted by T and B cells, but there's not enough of them to really fight off the infection. So the key point here is that these babies are born with incomplete immunity, so we really got to be very, very careful to prevent any kind of infection with them. And even though they get infections, we got to be really diligent about it. And most of the hospital-acquired infections in the NICU are instrumentation. Needles, tube feeding, mechanical ventilators. These are the things that causes hospital-acquired infections in this group, especially the fact that they have an incomplete immunity. The mortality rate for these groups is anywhere from 10 to 50%, and you can imagine the economic consequences, how much money it takes to treat these babies and get them well. So all of these factors are important when you think about immunity, think about instrumentation, think about medical procedures, and all of these medical procedures are used to keep the baby alive. So it's a double-edged sword, kind of sad. Here is a listing of the most common infections found in the NICU. The top of the list are bloodstream infections, either caused by a central venous catheter, CVC, or a umbilical catheter. Intravenous lines are broadly divided into two main categories. You either have short-term peripheral lines or central venous lines, CVCs. CVCs are essential in the Neonatal Intensive Care Unit for diagnostic and therapeutic purposes with the neonates. They are commonly used to provide fluids, give medications, TPN with these particular patients, especially the patients who have very low birth weights and those who are extremely low birth weight. Both of these populations really benefit from these lines. The problem is they get infected, and due to poor processes of actually placing the lines and actually managing the lines. So evidence has supported proactive strategies to prevent any kind of infections due to this particular case. In regard to ventilator-associated pneumonia, ventilator-associated pneumonia is defined as a nosocomial lower airway infections. Typically, it's a pneumonia in intubated patients after 48 hours or more of invasive mechanical ventilation. The problem with VAP is usually caused by colonization of potential pathogens in the endotracheal tube or around the mouth. As a result, many of these patients get really ill and potentially go into sepsis. So, again, evidence supports proactive strategies in the management of mechanical ventilation, endotracheal tubes, quick extubations, non-invasive ventilation. Any strategy you could put in place together that supports the infant as well as prevents infection is paramount. I just wanted to outline some of the devices that are commonly used for babies in the NICU. And they have found that a lot of times these devices are the same devices that keep the baby alive are also putting the baby at harm if they get a nosocomial infection from any of them. For example, due to the fact that they have immature immune systems and because they have an increased need for mechanical ventilation due to their premature growth, they are susceptible to all kinds of pathogens. So they have this term which they call device-associated infections that could come from a number of different things. For example, on the upper left, we have commonly known as the ventilator, right? We got the ventilator right here, that the baby's intubated. So just by the likelihood of intubation, you could possibly get a ventilator-associated pneumonia from that. Then you have feeding tubes, the TPN feeding tubes, or, different types of feeding tubes that can introduce pathogens. Then you got, pulse oximetry around the baby's foot. That can cause problems. Temperature monitors, EKGs, big one, umbilical artery catheter, big likelihood of creating sepsis. Also, intravenous infusion pumps. Again, big likelihood to cause central infections with the baby. So, these instruments that we use to keep babies alive are the same instruments that can cause harm to the patients. So every NICU across the country is different. If you've got good infection control practices in your NICU, all these devices do not make a big difference because you've got great ways of handling this. But some NICUs don't do such a good job and their mortality rates are much higher. So it all depends on the weight of the baby. It all depends on the protocols you have in place in your hospital, whether device-associated infections are a problem or not. So this is the way it is. Let's delve a little bit deeper into device-associated infections. As the slide I previously showed, there's a huge amount of different devices that are used to support the neonate in the NICU. And as respiratory therapists, ours is the mechanical ventilation, which is a biggie. Most infections are preventable. So in other words, why a baby gets an infection in the NICU has a lot to do with the way we do things in the NICU as healthcare practitioners. If you have two babies, each are 1,000 grams, and you put them on the same exact ventilator, but in 2 different NICUs, you might find infection rates can be different between those 2 NICUs. So what does that mean? That means that someone is doing a better job of preventing infections than another. So you can learn from that. So the saying is that most of these infections are preventable. For example, extremely low birth weight infants are at increased risk of getting infections. So you really need to take extra precautions with this population. And one of the ways to do it is to compare your infection rates based on device with different hospitals. So for example, you may notice that in your particular unit, you're getting a lot of ventilator-associated pneumonia. And you may say, what are we doing different than this other hospital that's 10 miles away? Why are they not having so many VAP cases? So sometimes sharing information and sharing protocols is a good thing. Also, you need to address any kind of problems that could occur. You have to do a root cause analysis on them. And way you could do this is with active surveillance programs. So what do I mean by active surveillance programs? Basically, you got to look at your devices. You got to see where your infection rates are coming from. You got to look for trends. And then you got to determine what kind of pathogen is involved. What kind of, is it a staph infection? Is it a MRSA infection? Is it a VRE infection? Is it a Acinetobacter? You got to find out exactly what kind of pathogen is involved in your unit. And then you got to consider antibiotic resistance patterns. Sometimes physicians could overly prescribe antibiotics, and what that does is kills all the good bacteria, and it makes the patient antibiotic resistant in the future. That is why there are so many gram-negative organisms that are resistant to antibiotics. They have this other thing called an antibiogram, where basically you look for antimicrobial therapy in your particular unit, and you compare it with other hospitals for best practices. So all of these things can improve the hospital-acquired infection rate, especially in related to device-associated infections. Really, it's something you can do, something you can improve, and you got to really work hard at it. As mentioned earlier, the CVC and umbilical catheters are one of the major routes of infections in the NICU. Umbilical venous catheters, commonly known as UVCs, are used to establish a secure central vascular route for the delivery of drugs and TPN for the babies. UVCs are usually inserted within the first few days of birth, and this is when you could visualize the veins in the umbilical cord stump. Evidence suggests that the use of UVCs rather than peripheral venous cannulas is better for the patient versus multiple sticks going to the patient. As with other types of central venous catheters, the CVCs, UVCs are also associated with complications, and also they're associated with infection. They did some tests with them, and they found that the most common infective agents found with the UVCs are staph infections, MRSA infections, and Acinetobacter infections. So, really great care needs to be taken when you use the UVC catheters, and also you have to realize that mortality rate can be anywhere from 3 to 20% with these particular lines. So this is another important route of infection for the babies. So let's talk about another device-associated infection, the ventilator. We're all familiar with the ventilator. The ventilator can be life-saving. It can help a patient breathe. Remember, a lot of these premature babies who are born don't have full lung development. The alveolus aren't developed, the bronchi aren't developed fully, so they really need some kind of formal support for ventilation. The problem with ventilation is that they get ventilator-associated pneumonia, especially with the fact that the endotracheal tube is uncuffed, and any kind of manipulation of that endotracheal tube can they can aspirate pathogens into a sterile environment in their lung. Typically, the VAP rate, they did some studies, and the VAP rate for the neonates is roughly around 14 over 1,000 ventilator days. And the likelihood of getting more, the longer someone's on a ventilator, the greater likelihood they're going to get a VAP infection. So the problem with VAP infections with the neonate populations is most of the pathogens found with these particular cases are gram-negative. Gram-negative bacteria are harder to treat, and they can really cause some real harm to the patient. Examples of that could be VRE. It could also be, what's the other one? Oh, Acinetobacter. So many different pathogens can be introduced into a baby during mechanical ventilation, and it has a lot to do with the manipulation of the endotracheal tube. So as you reposition the endotracheal tube, as you move the baby from one position to another, the likelihood of aspiration is great. So ventilator is a device that you've got to be concerned about, and you have to have practices that ensure that you can reduce the likelihood of a VAP infection with this population. So let's talk about the reasons for hospital-acquired infections. In particular, we're going to talk about the prevention of central line-associated bloodstream infections. Now, as we were saying before, this is the most common infection found in the NICU. And catheter-related bloodstream infections are the most prominent type of infections found in the NICU, and they are preventable. The number one reason for this is because of poor technique at the time of placement and then the ongoing care of the catheter site. This is the number one reason why you get an infection there. So what do you got to do? How can you improve this? Practice guidelines, evidence-based medicine has shown that practice guidelines for insertion and proper training of the staff is paramount. That means that the physicians who actually put these lines in, as well as the nurses who care for them, as well as the patients' parents who come in and hold the baby, they need to be gowned up, they need to wash their hands, they need to do everything within their power. They need to be educated so that this doesn't happen. Another very important thing is prophylactic administration of antibiotics. Sometimes you could give the patient a low-dose antibiotic prophylactically so that they don't get an infection. Also, topical emollients on the skin can reduce infection. Also, promotion of breastfeeding. If the mom could breastfeed the baby, this gives all kinds of antibodies to the baby and boosts the immune system. Obviously, you have to gown up your visitors who visit the patient, and gowning up the staff, respiratory therapists, nurses, doctors. Any kind of manipulation of the baby and the sites needs to be addressed. Also, proper hand washing techniques. You know, such simple steps can be done, but if you do all these things and you use practice guidelines for the insertion and the maintenance, you train your staff properly, you make sure people gown up, you could really reduce the likelihood of getting any of these types of infection. So let's talk about sepsis and the babies. Newborn infants are at a much higher risk for developing sepsis than children and adults because of their immature immune system. Remember, I was telling you that babies who are born premature have partial immunity. So the case is that where 1 out of every 250 births will be diagnosed with sepsis. Sepsis is one of the major leading causes of death in the first few months of the newborn's life. Infection rates can be anywhere from 13 to 15% of all deaths during the neonatal period, with the mortality rate reaching as much as 50% for infants who are not treated timely. So this is very serious. The combination of immature and slow responding immune system and the increase of it greatly increases the risk of infection. One reason for the increased risk is that antibodies, which help protect the mothers from infection, do not cross the placenta to the fetus until approximately 30 weeks of gestation. This is number one cause. The antibodies present at birth take time to reach optimum levels, and this also affects the protection the baby has. So the point is this: you really need to encourage breastfeeding with the baby. You need to try to secure that the baby is not born prematurely. I know it's easier said than done, but sepsis and babies are going hand in hand, and the mortality rate can reach up to 50%. So this is really pretty serious. There are many things that we could do to prevent sepsis, and we're going to break it down in some major categories. We're going to talk about before delivery, during labor and delivery, and after delivery. So there are certain interventions you could do. So say before delivery, we're talking about maternal health and nutrition. If the mom takes good care of herself, if the mom eats right, doesn't use any kind of drugs or alcohol, if she takes micronutrients and vitamin therapy, these could greatly enhance the birth weight of the baby, the fact that the baby might be born prematurely, and so on. This is not rocket science. You all know that if a mom takes care of herself, the likelihood of having a healthy baby is greatly enhanced. So let's move on to during labor and delivery. As said with during labor and delivery, hand washing is so important. You forget a little simple thing like hand washing techniques can greatly improve the likelihood that the baby will get sepsis during delivery. So while the mom is delivering, make sure that all the staff who are taking care of the mom wash their hand properly. Also, antibiotic prophylaxis at this point is really important too, especially for group B streptococcus. Also, some countries have used chlorhexidine during vaginal deliveries, and this has been shown to greatly reduce the likelihood of a sepsis infection. So there are many different steps that you could take during labor and delivery, and I just mentioned a few of them. Finally, we get after delivery. In regard to after delivery, again, hand washing is so important, and you need to really do this when you touch the baby, when you manipulate the baby, and when you warm the baby, and everything you do with the baby, you need to have some clean hands. Also at this point, if the mom could breastfeed, breastfeeding has been shown to greatly improve the immune response of the baby. For example, breast milk contains IgA, lysozymes, white blood cells, lactoferrin. All of these things have been shown to reduce the likelihood of sepsis. So all of these interventions work for the baby, works for the mom, and works for all of us in general. So what can we do as healthcare workers to prevent healthcare-associated pneumonia in the NICU? We have three basic strategies. One would be to prevent the transmission of the pathogenic organism. This can be done through proper sterilization or disinfection practices with equipment. Also, we got to use standard precautions. And third of all, we need to use isolation practices when appropriate. So one of the key points you need to do is you need to have some staff education and involvement in infection control practices. All providers should receive appropriate information relating to the epidemiology of the infection control procedures and for preventing healthcare-associated pneumonia. There should be procedures in place to ensure worker competency, including performance of appropriate infection control activities. Second of all, we need to do infection control surveillance. You need to look at different cases in the NICU for a pneumonia and then determine trends and then try to help identify outbreaks and other problems that occur. So routine surveillance of cultures of patients and equipment should be performed. Thirdly, prevention of transmission of microorganisms. Within the NICU, risk for acquisition of microorganisms could result in healthcare-associated pneumonia and can be reduced by, number one, proper sterilization. Number 2, prevention of person-to-person transmission. And these 2 things can really help the patient from getting sick. And then you really got to use some common sense. You got to wash your hands. You got to look at equipment. You got to try to utilize the equipment as short as you can. So use equipment as long as you can to support the patient. But when you don't need it no more, don't use it. For example, ventilators. Only keep them intubated as long as you can. And if you could use non-invasive ventilation or CPAP, that would be a much better idea. Let's turn our attention to ventilator-associated pneumonia in the neonates. VAP is not just exclusive to adults. It does happen with children, and when you really think about it, when you have a cuffless endotracheal tube, the likelihood of them aspirating secretions from their mouth is really high, and a lot of times those secretions have pathogenic organisms in them. Ventilator-associated pneumonia has a great impact on the morbidity and survivability of the babies in the ICU. It also costs the hospital a hell of a lot of money and increases their length of stay. VAP is a very common cause of infection in the NICU, and they estimate that anywhere from 6.8% to 32% of healthcare-acquired infections among the neonates is caused by VAP. So VAP increases the morbidity of the patient. It impacts their length of stay. It takes a lot of resources to manage them. And so you really got to do some VAP prevention strategies, which I'm going to get into a few slides later. But understand that VAP is nothing new to the neonates, and we really got to do something to prevent the spread of it, which I'll get into a little bit later. Let's explore some of the risk factors of VAP with the neonates. And evidence has shown that there are certain risk factors, especially with this population. For example, any use of opioids in regard for sedation or pain management have been shown to increase the likelihood of getting VAP. Also, frequent endotracheal suctioning. You should not just suction a patient every Q2 or Q1, whatever you got to do, only as needed. The more likely you intubate someone, the more likely you're going to suction them, and the more time you suction them, the more you're going to manipulate the endotracheal tube, which will cause aspirates to go down into a sterile lung field. A lot of times, also another risk factor is reintubation. Sometimes you might extubate the baby thinking they're going to do well, and then you reintubate them. All of this increases the likelihood of getting VAP. Some of the best choices that you could do, some ways that you could reduce risk factors is, number 1, use non-invasive ventilation such as nasal CPAP. Nasal CPAP has been shown to be quite effective of reducing VAP. It could support ventilation. So the earlier you could manage the patient on non-invasive ventilation, especially nasal CPAP, the better likelihood their outcome will be. Also, sometimes staffing can affect VAP rates too. Sometimes if you're short-staffed, it all depends on the acuity of what's going on in the unit, but sometimes how your staffer unit can impact VAP rates. So staffing properly is a very important thing. And also, they've done some studies. I've been to some hospitals in the past where I've been to their NICUs, and their NICUs are so spacious. In other words, you know, the isolates are separated by a good, 3-4 feet, and there's plenty of space for people to get around and get equipment. And they have shown studies that VAP rates decrease significantly when you take the baby and put it into a larger NICU versus a smaller unit, and also has a big impact on staffing. The more you staff properly, the less likelihood you're going to get VAP. Kind of amazing, but these are simple little strategies you can do with this population. Let's talk about the pathogenesis of VAP with the neonates. Under normal conditions, cough reflexes, tracheal bronchial secretions, mucociliary lining, cell-mediated immunity, and the phagocytic system of the body will protect the lung from any kind of infection. If any of these defenses are impaired or absent or overcome by pathogenic organisms, you will get a VAP infection. So these babies who are premature, who do not have a impact immune system, may not have the mucociliary lining with the epithelial cells and the cilia mobilizing secretions out of the lung, they are more likely to get a VAP infection than an adult. The microorganisms responsible for VAP can originate from oropharyngeal secretions. So basically, whatever pools above the cuff. Now think about this. These babies have cuffless endotracheal tube. So secretions that pool in the mouth can actually work its way down into the lung. The organisms causing VAP are noted to be most likely in the posterior pharynx. That's where most of the secretions occur, and that's where they work their way down into the sterile lung fields. Contaminated oral and gastric secretions can pool above the cuff, but obviously with this is a cuffless endotracheal tube, and then it works its way down. Neonates are more likely to get aspiration than adults. Also, if a neonate gets a gram-positive organism in the mouth that colonizes a trachea, the endotracheal tube within the first 48 hours, that is called early set VAP. So if you happen to get a VAP infection within 48 hours, most likely it's a gram-positive organism, most likely it's a little bit more benign. But if you happen to get a VAP infection greater than 48 hours, that is typically a gram-negative bacteria, and it takes a little bit longer to treat. And the morbidity with that is much higher too. I just wanted to highlight some of the features from the last slide. Remember, the aspiration of contaminated oral secretions because of the uncuffed endotracheal tube is one of the predisposing factors why the neonates get VAP. A lot of gram-positive organisms in the mouth colonize the mouth under normal conditions, and they work their way down into the airway, the lower airway. And if this happens within the first 48 hours, it's called early onset VAP. Gram-negative bacteria actually colonize after 48 hours, and those are the ones that are resistant and more difficult to treat. So these are a little bit about the VAP pathogenesis. So let's talk about some prevention strategies for VAP in the infant. As I mentioned earlier, aspiration is the major risk factor for the development of ventilator-associated pneumonia. So the idea is any kind of device that is in the mouth, such as an endotracheal tube, a tracheostomy tube, a tube feeding, if you could remove these tubes as soon as medically and clinically indicated, that would be a great thing. So if you happen to have mechanical ventilation, invasive mechanical ventilation, and you could put the kid on non-invasive ventilation such as nasal CPAP, that would be the best thing you could do. Another thing, if there's no medical contraindication, the head of the bed should be placed anywhere from 30 to 45 degrees, especially with mechanical ventilated patients. This has been shown to work for adults, and it could work for the infants too. Another thing is you need an evidence-based program for oral hygiene. So in other words, you need to have a program in place in your hospital for oral hygiene for these babies, and it needs to be evidence-based and needs to be followed to the T. Another very important thing is suctioning. The goal with suctioning is to use a closed system, and we all familiar with the Ballard system. These kind of systems work much better. First of all, they reduce the likelihood of getting hypoxic. They reduce the likelihood of getting any kind of cardiac compromise. It also, if you happen to have PEEP in the system, it's a good way of maintaining PEEP, because if you use an open system, all the physiologic PEEP, all the PEEP that you administer is removed when you open up that system. Also, it reduces the environmental contamination of the endotracheal tube. So all of these factors speak to the fact that you need a closed suctioning system, and you should suction when needed. Don't just do a Q2 or Q1. Make sure you do it when the patient needs it. So I have a little bit more strategies on the prevention of VAP with the neonates. Number one, if the patient is intubated, and obviously they have an endotracheal tube and they have the ventilator circuit, you want to keep the endotracheal tube and the ventilator circuit in a horizontal position. And the reason you want to do that is it reduces the likelihood of secretions being transmitted down into the lower respiratory tract. Studies have shown that ET tubes that are horizontal, basically sideways, have less likelihood of introducing oropharyngeal secretions down the lower respiratory tract. And when you do that, you reduce the likelihood of pneumonia. Another thing they've done with studies is show that if the patient or the infant is in a lateral position, this has also been shown to reduce the likelihood of aspiration of gastric secretions into the trachea. And then the final thing, as I mentioned before, is, try to reduce the likelihood of using a non-supine position. If you keep a baby flat on its back, the likelihood of them aspirating is greater than if their head is elevated or if they're in a lateral position. So these are additional some tidbits of information that you could use to prevent VAP. One of the most effective ways of reducing healthcare-associated infections in the NICU is with hand hygiene. I mean, you hear this all the time. You hear about wash your hands, wash your hands, wash your hands. We have actually training modules at our hospital that teaches you how to wash your hands. A lot of people don't wash their hands long enough. And also, you got to realize that using alcohol-based products versus soap can matter depending on the type of pathogen you're talking about. For example, in C. diff. But when we're talking about washing your hands and reducing the likelihood of getting infections, there's so much data on this, and it's so true. The problem with this is that many people are not compliant. Either they don't wash their hands or they wash their hands incorrectly. So the most effective method for reducing healthcare-associated infections is to wash your hands. And studies have shown to reduce central line and bloodstream infections. This is what you got to do. The CDC published some guidelines for hand hygiene to healthcare settings in 2016. But a recent analysis said that even though all these guidelines are in place, even though we're required to take hand hygiene modules on how to wash your hands, compliance rate is bad. So in other words, either you don't do it or you don't do it correctly, and a small majority of the people do it correctly. So I can't stress enough how you need to wash your hands. You need to use soap and water. You need to keep the water running for at least 20 to 30 seconds. It's not like a 10-second thing. And you can use alcohol-based products, but really, spend a little bit more time with your hands in the water, at least 20 to 30 seconds. Evidence has shown that this has worked very well for all populations. So the big debate, do you use soap or use alcohol-based gel? Which one is better? There are new studies coming out every day, but the most current study by the CDC says that the use of soap and water is more effective than alcohol-based gel. But there are some studies that counter that, where they say that the alcohol-based gel is more compliance. In other words, if you use the gel, you're more likely to use the gel than you are going to wash your hands properly. So as I mentioned in the previous slide, if you are going to wash your hands, wash them for at least 20 to 30 seconds with soap and water. If you have a C. diff patient, of course, use soap and water. Yes, you can still use alcohol-based products. They did a study, Lawson and his team did a study on the effectiveness of hand washing versus alcohol. and they found that there was really no difference in microbial counts on the nurse's hands in the NICU. They also suggested that there's no superior method versus one over the other, but like I mentioned, there are certain organisms you need soap and water. The problem is with compliance. Even with soap and water, even with alcohol-based products, it seems that people are more compliant with alcohol-based products than they are with soap and water. And if they do use soap and water, what percentage of them do it right? How many of them actually spend a good 20 seconds under the sink we're washing their hands with soap and water? So my recommendation is use both, but if you're going to wash your hands, wash it for at least 20 seconds. The reason I'm beating to death hand hygiene is because it's so important. I just want to drill this into your brain. The World Health Organization created some guidelines on hand hygiene. And what they said, when to use soap and water, when to use an alcohol base. Soap and water should be used when there's visibly soiled body fluids on your hand. And also after toilet use. Also, to exposure to potential spore-forming pathogens. Think of C. diff. So soap and water has its value. It's been shown to be more effective if you do it right than alcohol-based. But their alcohol-based products are still good. Before and after touching patients is a good reason to use alcohol-based. Before handling invasive procedures. When you come in touch with body fluids such as mucous membranes, non-intact skin, or wound dressing, then you really want to use soap and water. It's between touching contaminated body sites with another body site. Also, when you contact inanimate objects, and such as a ventilator, or such as a doorknob or a stethoscope, no, or after removing gloves. So alcohol-based products have their value in certain conditions, and people are more compliant doing that. But just remember, soap and water is the best, but just spend a little time doing it. Let's talk about breastfeeding and the reduction for the risk of infections. I could not speak more good things about the mom breastfeeding the baby. The use of human milk feedings has been associated with the lower risk of sepsis and necrotizing enterocolitis with the preterm infants. Also, human milk contains a large number of immunoprotective substances, prebiotics, probiotics, and is shown to decrease the incidence of GI and respiratory infections in infancy. So the list goes on and on. Human milk or breastfeeding has actually been shown to secrete certain IgAs. It also secretes macrophages and lymphocytes that are used for immunity. It secretes molecules that have antibacterial properties. And because the babies are born with a partial immunity, when a mom breastfeeds a baby, they build up all these immunologic factors going on that protects the baby and helps the baby from so many different modalities that they could get. So I strongly encourage moms to breastfeed their baby, and if it's possible, even if they're preterm, you speak with your doctor and see what you can do. But breastfeeding is a real win-win situation for the baby as well as the mom. What other ways can we reduce the likelihood of getting a healthcare associated infections for the neonates? And there is a few different opportunities here. First of all, to get the appropriate vaccinations of healthcare workers. For example, the influenza vaccine. Or also in today's environment, the COVID vaccine. So as healthcare workers, we've got to make sure that we are healthy because, we come in contact with the patient. So vaccination is a very good way to start protecting the neonates. Another way of doing it is cohorting patients in certain outbreaks. For example, Candida and MRSA outbreaks can result in the baby being moved to a different room in NICU. I know this could be tough for some hospitals because I've seen where some hospitals don't have the space to move. But we were lucky enough to have a separate, we had our NICU, and then we had a room to the side that was used for education. But in times of, we had isolate and cohort patients, we would use those rooms. And we've had MRSA patients, we had Candida patients, and we moved them to that location so that they would be separated from the rest of the babies. Also, visitation guidelines. You know, we had to become very strict with some parents. We had many parents that would come up to see their babies, and we had yellow gowns and masks and gloves. And before you know it, they were taking the mask down, or they were taking the gloves off, or the gown was up around their shoulders. So we really had to become a little strict with the parents. We had to tell them that, you know, it's wonderful that you're visiting your baby, but you got to protect your baby just the way we're protecting your baby. So a lot of times these patients came in, the parents came in to visit the baby, and we had to have policies in place, and we had to be able to enforce those policies to make sure that the baby was healthy and well cared for. We want the baby to see their mom. We want the baby to see their dad, but the dad needs to, and the mom needs to understand the process of infection control. So these are good methods to use. So let's talk about antibiotic use and misuse. And you're going to say, why is that important to babies? First of all, I want to read you this statement. Use and misuse of antibiotics can be associated with alterations in the neonate's microflora and the development of antibiotic resistance. So here you got a newborn baby who has no kind of illness, and you end up giving some form of antibiotic. This can be very bad news for the baby. Here's why. We're going to talk about the microflora. First of all, during birth, bacterial colonization of the gut occurs. In other words, when the baby is born, their GI tract is free from any kind of bugs or any kind of bacteria. But as a natural consequence, within 2 to 3 days, the gut starts filling up with bacteria that are part of the normal flora. And the bacteria species such as Enterobacteria, Enterobacteria, Streptococci, Staphylococci, all of these bugs start being part of the microflora. And you say, whoa, that's bad. These are bad bugs, but not necessarily. These bugs, and plus hundreds of other bugs, get into the stomach, and this is what makes up the microflora. And when this kind of scenario occurs in your gut, you're in good shape. We must have all heard how if you take an antibiotic and it kills the natural flora in your gut, you end up getting C. diff. So this happens with the babies too. Just when they're developing a flora, microflora in the belly, and you give them antibiotic, it kills those biotics, and that's how antimicrobial resistance occurs. In antimicrobial resistance, there's two types. One is known as intrinsic, and the other known as extrinsic. For example, gram-negative organisms. All gram-negative organisms are genetically resistant to vancomycin. You would never give vancomycin to a gram-negative organism because it just genetically doesn't work. Regarding extrinsic, that is like, for example, this is acquired resistance. So extrinsic resistance means that you develop an antimicrobial resistance because you keep on taking it. Examples of that would be Staphylococcus as well as ESBL. So understanding whether the organism is intrinsic resistant or extrinsic resistance is key. Understanding the microflora of the gut is really important. Also, I wanted to mention that babies that are born vaginally normally develop a microflora within 2 to 3 days. Babies that are born C-section develop much later, sometimes up to 6 months to develop a full microflora. So there is a difference in the microflora between a C-section versus a vaginal delivery. So let's talk about antibiotic use and best practices. So, you don't want to use a broad spectrum antibiotic initially for a long period of time because it kills every particular bug in your body. So what you really want to do is use a selective choice of what kind of antibiotic will work best for that particular type of infection. So this is what I mean by judicious use of antibiotic agents. You really want to use an agent that will kill the exact, so if you can identify what kind, if it's a streptococcus infection or if it's a VRE, you really want to use the exact antibiotic that would kill that particular bug. Also, prolonged use of antimicrobial agents builds up resistance. My brother is a diabetic. He's been having recurrent infections, for years. He's resistant to a lot of different antimicrobials. Also, third one, limiting use to only those situations in which a bacterial infection is likely. If you suspect the baby has a viral infection, an antibiotic's not going to do anything. So you really got to identify what kind of pathogen it is. And also, where I say use the narrow spectrum on the basis of susceptibility testing, think about a petri dish when you determine what kind of bacteria respond to what kind of antibiotic. So you really want to use a narrow spectrum antibiotic based upon the susceptibility of killing that organism. And also, you want to treat for the appropriate duration. For example, studies have shown that if you have a bacterial infection and the evidence shows that you need to use this for 7 complete days, use it for 7 complete days, because if you use it for 3 or 4 days, you could be asymptomatic and you won't see the bacteria, but it's not killed and it'll come back, and then you have to go back on another bout of antibiotics. So the key point here is use the appropriate antibiotic, use it for the appropriate amount of time, and be very careful about continuous use of antibiotics. There's a term called antimicrobial stewardship, and what that means is that when you're in the NICU, you really want to audit antimicrobial use by practitioners. You want to make sure that the physicians and the nurse practitioners who administer these medications are educated. You also want to make sure that clinical guidelines and pathways are selected based on evidence-based medicine. Because, in other words, you really want to watch the use of antibiotics, and you also want to make sure that studies of resistance doesn't occur in your NICU. So these are called antimicrobial stewardship, which means that you're really watching and you're creating guidelines based on evidence-based medicine, and that you're really making sure that no particular practitioner is abusing the use of antibiotics with their patients. In summary, immunity is decreased with premature births. As I was telling you earlier, these babies are born with an incomplete immunity system, so you really got to understand that they are susceptible to pathogens. Also, device-associated infections, central lines, umbilical lines, mechanical ventilators, TPN, all of this can cause infections. If you could put the patient on non-invasive ventilation, you could reduce the VAP rates. That simple. As soon as you could get them to NIV, the better. Catheter-associated infections can be reduced with proper technique and evidence-based guidelines of putting them in. Hand washing. I can't say enough about that. You got to wash your hands. And also surveillance techniques. You really want to do surveillance technique, look at your antimicrobial use, look at your infection rates, look at your staff, and make sure everything works perfect. I want to thank you for joining my presentation. I got 4 different references here that could help you if you want to learn more. And I really appreciate your time here, and I hope you learned a lot from it. I thank you very much. I know there was a lot of information to go across here. You have a great day, guys.